Okay, I wanted to thank all of you at Nidek for asking me to speak, and thank Park for arranging this. I use an MP1 in my low vision and retina practice, and I wanted to discuss how I use it, why I use it, and what it provides for me. I'm a retina specialist and also a low vision specialist, and my area of research has been mainly how retinal and macular diseases affect visual function. So I've done a lot of microperimetry, so to speak, for many years with the rodent stock SLO, and now with an MP1. And I was fortunate to get a grant from NIH in the early 1990s to study geographic atrophy, both in terms of visual function and in terms of how it progresses over time. So we've generated a lot of data from that as well. Now, my financial disclosure is that I'm getting an honorarium from Nidek for giving this talk, but no other support. I'm a consultant to a number of pharmaceutical companies who are trying to develop drugs for dry macular degeneration and geographic atrophy. And NIH has supported much of my work related to microperimetry, both in the past and currently. Okay, so why? And please feel free to interrupt me with any questions or comments. Why do fundus perimetry or microperimetry? I prefer the term fundus perimetry or macular perimetry because the micro gives you the impression that you can really dissect things to the micron level, which you can't do, although as we'll discuss, the MP1 allows you to get closer to delineating things in their retinally correct position. But I'm going to use the terms interchangeably. So the reason that microperimetry or fundus perimetry is needed is because people who have a central scotoma cannot be measured accurately with conventional visual field techniques. And there are two problems. The first is that if you've lost the fovea, so if the person does have a fixation site outside the fovea, an eccentric fixation site, when they're looking at the cross or whatever the fixation target is, let's say in a Humphrey or a Goldman, they may not be looking, they may not be centering it on their fovea, let's put it that way. They may be putting their, we call it an eccentric PRL, a preferred retinal locus, where they're now focusing. They may put that right in the center, and then your mapping of where scotomas are and what's going on is wrong because it's pegged to where they're fixating, which is not the center of the vision. The other problem is that once people have central scotomas, generally fixation is much less stable than it is when people use the fovea. So that you may be able to measure a scotoma, but given the eye movements, you're not going to measure its borders accurately. And conventional visual field testing does not really have a mechanism for correcting for either of these problems. So why can't you just use an Amsler grid, which was the standard way of monitoring central visual fields, let's say 20 years ago? On an Amsler grid, you have, it's like a piece of graph paper with a spot at the center, and you tell the person to center themselves on the grid, and can they see the center spot, and are there wavy lines or distorted lines or missing lines? The problem is, first of all, you don't know how the patient is fixating when they do that. Even if you say center yourself so within the four corners of the grid, you don't know that they're doing that. So again, you don't know where they're placing fixation and what they find and what that correlates with. But the other thing is there was a study done in the 1980s at Wilmer, and what they did is they took people who had gotten heavy laser photocoagulation, which was the mainstay of treatment for wet macular degeneration then. So that kind of laser treatment destroys all the underlying layers. So those areas were clearly blind spots. There was no question. And they did Amsler grid testing on people who had these, and 40% or more of them could not pick up their defect on the Amsler grid. And the reason they couldn't do it is because there's what's called a filling in phenomenon or perceptual completion. It's called that the the brain wants to make something that makes sense. And so if you have an area, and we know it happens all the time because we all have the so-called physiological blind spot off to the side where our optic nerve is, but we're not aware of it. We sort of complete it. And it's the same thing if you have a central blind spot. The brain completes it to try to make sense of it, so to speak. So that the Amsler grid is not necessarily a most reliable thing for measuring central field. I actually try to do microperimetry on most of my patients, almost all of my patients, but I use another technique which is actually impressed now. It's a modification of existing techniques. I call it a face field, and what I have people do is I have them cover one eye and I tell them, look at my nose so you can see it as clearly as you can. And then I make sure they're doing that they're fixating on my nose, and I say, while you're looking at my nose, I want you to tell me if there's part of my face that's missing or blurry or distorted. And then they tell me what they see, and it happens that the face is a much better target for some reason for picking up scotomas than the Amsler grid is. People are very aware if a piece of your cheek looks blurry or they're not seeing your eyes or something like that. So I don't use an Amsler grid at all, but and I'm going to show you some face field later, but anyway, that it doesn't provide enough information for what you need. So what can microperimetry do? First of all, you can map the pathology to the retinally correct location. In other words, where there's a dense scotoma, you can test precisely over the areas of interest on the retina and see what's going on there. Are the patients seeing, do they have a relative scotoma or a dense scotoma there? You can see the relationship of fixation to the scotoma. When people have a central scotoma, many of them, and it's still, the whole process is sort of unclear, many of them have the ability to establish a PRL, a preferred retinal locus for fixation, and they can use it almost as what we call a pseudofovea, meaning that their eye movements now move what their object of interest right onto the part of retina that's seeing that they want to use. And the problem is that it's really not well understood why certain people are able to do it and certain people are not. So for example, if you're testing visual acuity, you may have two people with the identical size scar, let's say, from macular degeneration, and one person knows that she has to look up, let's say, and move the blind spot out of the way that way, and then can read fairly fluently, and the other person is looking at the same chart but moving their head all over and not scanning back and forth, telling you that letters are moving in and out and having much more difficulty. So there's a lot of work going into trying to understand that, but the first step of it is understanding where people do put fixation and how that can be modified. And if we have more time, I'll talk about that at the end. And so the other thing, in terms of retinal disease, we're fortunately getting to a time where there are going to be clinical trials for a variety of conditions. I have a particular interest, for example, in Stargardt disease, which is the juvenile form it's a form of juvenile macular degeneration. That's the most common form. And in that disease, it's almost everyone who has it has the same genetic abnormality. It's